Blood transfusion has been defined as transfusion of more than 10 units of packed red blood cells or whole blood within 24 hours of patient's admission, or more than 4 units of the same have been transfused, either it is packed red blood cell or a whole blood within first 4 hours. Now, if there is transfusion of more than 20 units of blood in first 24 to 48 hours, within 2 days of admission of the patient, if there is more than 20 units of transfusion, it is called as ultra massive blood transfusion. This is a recent term. So these patients who require more than 20 units of blood in first and second day of the admission, it is called as ultra massive blood transfusion. Right? So what are the indications for massive blood transfusion? So the most common indication would be, as we discussed yesterday, a class 4 shock, where the patients are non-responders, is a class 4 hemorrhagic shock. Also, it can occur in a obstetric bleed if there is a abruptio placenta, or during hysterectomy if there is a injury to the internal iliac artery. So that can also lead to the shock and need massive blood transfusion. If the patient has massive GI bleed, either in the form of hematochezia or hematemesis, or if the patient is on cardiac surgery, undergoing cardiac surgery, or some vascular surgeries. So all these are the indications, of which the most common indication would be a class 4 shock for massive blood transfusion. Right. Now there is a score which predicts the massive blood transfusion. It is called as a ABC score. So ABC score contains the following criteria. The first one would be a heart rate of more than 120, systolic BP of less than 90, or there is positive finding on the fast, or there is a penetrating torso injury, penetrating injury to the chest and abdomen. So either the systolic BP is less than 90 or the heart rate is more than 120, fast is positive, or there is a penetrating torso injury. Each one of them is given a score of 1. And a score of at least 2 is a criteria. So ABC score of at least 2 is a criteria for initiation of MTP. It has to be there. At least 2 should be there. But you see that any shock patient will obviously have a systolic BP of less than 90 and heart rate of more than 120. It doesn't mean that all of those patients need MTP. Only 50% of these patients will need MTP. Rest 50% can be managed with normal blood transfusion. So the positive predictive value. So the percentage of patients in which it predicts positively that MTP is needed is a 50%, right? But this is the best score of all the scores that are available for trauma to predict massive blood transfusion. Then what is the criteria for massive blood transfusion? So the criteria is, first, there has to be a ABC score of at least 2. Second criteria is that the patient is in persistent shock despite fluid therapy and initial blood transfusions. That is a criteria. So either the ABC score is of at least 2 or the persistent shock despite the fluid therapy and initial blood transfusions. So how to go about it? Procedure of massive blood transfusion. Here, once the criteria for MTP is fulfilled, you initiate MTP. So when you initiate MTP, on one side you will alert the blood bank. But on other side, because these people are already in class 4 shock, the initial trauma management will have been done. Already the airway plus breathing plus circulation will be taken care of. You send investigations. Initial investigations will already be sent, which includes CBP, the coagulation profile, ABG analysis. In the ABG, it includes pH study, the lactate levels, the glucose levels, and if possible, TEG and electrolytes. All this will be initially sent. Along with that, you manage hypothermia, and you manage coagulopathy. So this has to be managed. Along with that, you keep ready for warmers because once you get all this fluid, blood from the blood bank, it will be in a cold storage at 4 degrees Celsius. So you need to warm them because it will not accentuate hypothermia again that we have discussed. So you keep the warmers ready and just not preheated blood. You can also give IV fluid warmers, IV fluid line warmers. So as you pass the blood through the fluid lines, through the IV lines, you can warm those IV lines also. So all this is kept ready on one side. And once you alert the blood bank, this blood bank will issue the first box. And the first box contains 4 units of PRBC plus 2 units of FFP plus 1 unit of platelet. This is given. The first box is released, which contains 4 BRBC, 2 FFP, 1 platelet. As I told you, these patients are in non-responder stage, class 4 stage. There is no time for cross-matching or even typing. So what this box contains is it contains type O PRBC. But if the patient is a known RH negative or any female of reproductive age group, female in reproductive age group, this will be given as O negative blood is given, right? And FFP will be AB. So type AB plasma and type O PRBCs are issued. This is first box. The first box is transfused. And as soon as it is transfused, the second box is issued. Now the second box also contains 4 PRBC of same plus 2 FFP plus 1 platelet. This is same. And then again, when it is required, every 30 to 60 minutes, they keep on issuing a new box. Right? Along with that, if tech is suggestive of the need for FFP or cryoprecipitate or specific factors like factor 8A, even these can be issued once the second box is issued. So after this, as the need requires, every 30 to 60 minutes, a new box with same composition is issued. Right? So now, when you do that, how to monitor the patient? What are the investigations to be sent? So before initiation of MTP, we'll have sent all the blood investigations. And every half an hour, you repeat, you do a ABG analysis. This arterial blood gas will help you to know about pH. It will help you to know about the glucose levels, about the lactate levels, about the serum electrolytes, including calcium. So this you know on ABG analysis. This you do every 30 minutes. And after every 5 PRBC transfusion, you transfuse 5 PRBC, you send for CBC, INR, platelet, APTT, TEG if possible. This has and fibrinogen levels. Right? So this is massive transfusion protocols. You ask the patient, blood bank to initiate MTP. They will issue the first box, which contains 4 PRBC, 2 FFP, 1 platelet. Then again, they issue the second box. After every 30 minutes, they will issue subsequently boxes, and you get a TEG done. If it needs FFP or plasma, no, FFP or platelets, they will issue FFPs and cryoprecipitates also. And when you want to monitor them, before initiation, you send all the blood investigation. After you initiate, every 30 minutes, you send the ABG, which notes all of this. Along with that, you send 5 PRBC. Along with that, after every 5 PRBC transfusion, you send these investigations, right? So what are adjuncts in this? Along with that, you can use the cryoprecipitate as an adjunct. The factor 8 can be used as an adjunct. As I told you, tranexamic acid is also given if the patient has presented within 3 hours of injury, and you should treat hypothermia. This is non-negotiable, and treat the coagulopathy. These are the urgents. So when do you stop this MTP? Right? So what are the goals you need to achieve? So the HB should reach at least 7 to 9 gram per deciliter, and the mean arterial pressure should reach at least 55 to 65 millimeters of mercury. The platelet count should reach to more than 50,000. INR should become less than 1.5, and the fibrinogen levels should become 1.5 to 2 gram per liter. Normally is 1.5 gram per liter, so it should become 1.5 to 2 gram per liter. And the temperature should become more than 35 degrees Celsius, and the pH should come back to a normal range of 7.35 to 7.45. When these goals are achieved, you stop the MTP. Okay, these are the goals of MTP. Right. So the next part would be what are the complications. So, as I told you, hypothermia is a complication of all the transfusions. Whether you give a blood or you give fluid, because they are stored at a room temperature, ambient temperature, or at a lesser temperature, that will produce hypothermia. You can prevent this hypothermia by using warmers. Either you use preheat the blood or you pass it through a warmer of the IV line. So that is hypothermia. Because you don't treat the hypothermia, it will again lead to coagulopathy, and that cascade keeps on occurring. Second problem would be acid. Second problem will come back here later. So second problem would be coagulopathy, right? So already there is trauma-induced coagulopathy. Along with that, if you transfuse PRBCs are not going to contain any clotting factors. So along with that, they will cause the dilution that will lead to dilutional coagulopathy. So to prevent this only, the FFPs are also added. Right? So that is coagulopathy. It is same as that of the trauma-induced coagulopathy and dilutional coagulopathy. And third would be metabolic derangements. Now, most of the centers, it is the blood is stored with citrate. So there is sodium citrate. Now, whatever the sodium citrate is there in 1 unit of blood, this sodium citrate will release around 23 milliequivalents of bicarbonate. When it releases bicarbonate, this will cause metabolic alkalosis. There is alkalosis. Again, because there is alkalosis, the coagulation enzymes will not work properly, and that leads to coagulopathy. But more than that, what happens is because there is alkalosis in the blood, to correct that alkalosis, on the cell surface, there is a hydrogen potassium transporter. Now, there is in the blood, there is increased level of bicarbonate, which is alkaline. So, to buffer that, all the H plus which is present in the cell will come into the blood so that it will buffer the alkaline HCO3. But what happens because H plus comes outside to maintain the electrical neutrality, the potassium is pushed inside. As a result, all the potassium in the blood will enter the cell that reduces the potassium content in the blood, and that leads to hypokalemia. Right? Also, that is why alkalosis always causes hypokalemia. Also, the citrate which is present in the stored blood, this citrate will combine with ionized form of the calcium. Calcium in the blood exists in two forms. One is free form, which is an ionized form. Another is albumin bond. Because albumin is already bound, citrate cannot bind to that. So the rest 50% of the calcium, which is in the ionized form, citrate binds to this ionized calcium, and that leads to hypocalcemia. It is this ionized form which is responsible for all the effects of the calcium that leads to hypocalcemia. Hypocalcemia can produce paresthesia. Hypocalcemia can produce prolonged QT, and this prolonged QT can produce arrhythmia or sudden cardiac arrest. Even hypokalemia can produce arrhythmias. But as you store the blood for a longer period of time, the potassium is released out of RBCs into the bag, and that can also produce hyperkalemia. So it can be both. It can be either hypokalemia or it can be hyperkalemia. Hypokalemia is because of the citrate induced alkalosis. Hyperkalemia is because of three reasons. It is one, because the stored blood contains all the potassium in the RBCs will be released into the blood bag. So the stored blood contains naturally more potassium that produces hyperkalemia. And this is accentuated if it is transfused more rapidly, which is more common in a massive blood transfusion. Also, this is accentuated if it is given through a central route rather than a peripheral route. The effects of hyperkalemia will be more pronounced because naturally there is increased flow rate compared to the peripheral route. So these are the three causes and accentuating features of the hyperkalemia. So the metabolic derangements may be hypokalemia or hyperkalemia, hypocalcemia, and alkalosis. These are the metabolic derangements. Then this can cause allergic transfusion reaction or anaphylactic transfusion reaction. If there is just an allergic transfusion reaction, the patients will have hives and itching. You stop the transfusion temporarily, give steroids, and then you can continue the transfusion. But if the patient has an anaphylactic reaction, patient will develop angioedema, there will be hypotension, and because of profound bronchoconstriction, there will be wheezing. If these patients develop anaphylactic transfusion reaction, you stop the transfusion, give them on bronchodilators and steroids. Right. So these are the other effects: allergic transfusion reaction and anaphylactic transfusion reaction. Next would be hypotensive transfusion reaction. So those patients, you know that one of the side effect of patients who are on angiotensin receptor blockers, they will produce bradykinin. And this bradykinin is a vasoactive kinin that will cause cough. So, in patients who are taking angiotensin receptor blockers, if platelets are transfused, this will cause the activation of vasomotor kinins. And these vasomotor kinins are known for two reasons. One is they cause bronchoconstriction. Second is they cause vasodilation. So because of profound vasodilation, that reduces the BP. So fall in the BP by more than 30 mmHg on the initiation of transfusion is called as hypotensive transfusion reaction. Usually seen in patients who are where platelets are transfused. In those patients taking angiotensin receptor blockers, there is stimulation of the vasomotor kinins and the BP that will cause vasodilation that reduces BP. And if it becomes more than 30 mmHg, this is called as hypotensive transfusion reaction. So this is sixth. Seventh would be a transfusion associated sepsis. Right? This is because if the blood products have been previously infected, and these patients will develop fever with chills and rigors and all the signs of systemic inflammation. Plus, there can be even hypotension. Eighth would be febrile non-hemolytic transfusion reaction or acute hemolytic transfusion reaction. Now, acute hemolytic transfusion reaction is when there is incompatibility. When there is incompatibility, there is a graft versus host reaction. This produces intravascular hemolysis. When there is intravascular hemolysis, the patient will have fever with chills. Plus, this also leads to disseminated intravascular coagulation that leads to consumptive coagulopathy. So, there will be bleeding from the sides and there is generalized body ache if it is acute hemolytic transfusion reaction. In febrile non-hemolytic transfusion reaction, what happens? It is febrile because the patients have only fever. It is because of the WBCs in the donor bed, in the donor PRBCs. Most of the times, there will be some amount of WBCs. These WBCs raise the thermoregulatory center, thermostat, and that produces fever. So this is self-limiting, can be treated with just NSAIDs, but this requires stoppage of the transfusion. That is febrile non-hemolytic transfusion reaction and acute hemolytic transfusion reaction. So the other complication would be transfusion-related acute lung injury or transfusion-associated circulatory overload. Transfusion associated circulatory overload is pretty straight, meaning if the patient has a underlying cardiac disease, he has a underlying cardiac disease, coronary artery disease, or congestive heart failure. In such patients, when massive blood transfusion is done, the heart is unable to cope up with the transfusion, and that will lead to the further decompensation of congestive heart failure. When there is decompensation of congestive heart failure, it causes cardiogenic pulmonary edema. And there is all the signs of right heart failure and left heart failure. JVP is raised, and there is tender hepatomegaly, there is pedal edema, there is systemic edema, and the patient has orthopnea, patient has dyspnea. Right? All these features will be seen, and this happens within 6 hours of transfusion. This is just because of volume overload because the heart is failing. Treatment would be to give a diuretic and slow down the rate of transfusion. TRAL is transfusion related acute lung injury. Now, this also happens within 6 hours, but this is non cardiogenic pulmonary edema. Here, what happens? The stored blood, if it has been the donated blood, if the donor had received previous transfusions, then there will be sensitization of the WBCs there, and there will be formation of anti-neutrophilic antibodies and anti-HLA antibodies. So if the donor has been received multiple transfusions before, and if there was sensitization of the WBCs in the donor, there would have been anti-neutrophilic antibodies and anti-HLA antibodies already present. These, when enter into the recipient, they will attack the recipient WBCs. Now, these recipient WBCs get activated and they will stimulate the immune system. And when they stimulate the immune system, there is release of reactive oxygen species, free radicals, and cytokines. These will damage particularly the pulmonary capillary endothelium. And when there is a damage to this pulmonary capillary endothelium, that will cause the exudation of the fluid. And when there is exudation of the fluid, that will lead to the pulmonary edema. And the heart is not the reason for this. So it is a non-cardiogenic pulmonary edema. Right? So TRALI occurs within 6 hours. TACO also occurs within 6 hours. TACO is on the underlying cardiac disease. It is just a fluid overload state, and there will be all the features of right and left heart failure. But TRALI is because of the primed WBCs, which get activated by the anti-neutrophilic antibodies and anti-HLA antibodies that release the reactive oxygen species, which cause damage to the pulmonary capillary endothelium and exudation, and it is a non-cardiogenic pulmonary edema. It is usually within 6 hours of the transfusion, but any respiratory distress, if it develops after 6 hours of transfusion, it is considered to be an ARDS rather than TRALI or TACO. And if these patients are obviously in the class 4 shock, so if the patients have been inappropriately, injudiciously resuscitated, more IV crystalloids had been given before initiation of the blood transfusion, then these patients might have developed ARDS. So if TRALI occurs without previously existing ARDS, it is called as type 1 TRALI. If TRALI occurs on the background of the ARDS, where the prognosis is much worse, then it is called as type 2 TRALI, right? So without ARDS is type 1, with ARDS is type 2 TRALI. So is this clear?
Yes,
Hello.
sir.
So this is about massive blood transfusion. So you write about the definition, and also the definition of ultramassive blood transfusion, indications, the score, criteria, how is it transfused, and when to stop, the goals that are achieved, and all these 10 to 11 complications of massive blood transfusion. All these complications are also similar for normal, any blood transfusion can have these complications also. So that completes everything about hemorrhagic shock. So the last topic in this chapter would be septic shock. Now, the septic shock is a type of vasodilatory shock. In the previous classes, what we understood is that whenever there is shock, there has to be peripheral vasoconstriction because of increased sympathetic tone. So as a result of which, there has to be a vasoconstriction and it has to be a cold shock with cold peripheries and extremities. But there are certain examples for the vasodilatory shock. So the most common cause for a vasodilatory shock is a septic shock. But if there is a spinal cord injury, spinal cord injury above the level of T6, right? It can be either because a tumor is compressing onto the spinal cord, or there has been an injury to the spinal cord because of the vertebral fracture, or there is no fracture, but there is a contusion to the epidural layer around the spinal cord, and that has produced a EDH in the spinal cord that is compressing onto the spinal cord, or there has been complete transaction of the spinal cord, or there is an infection of spinal cord. All this will reduce the sympathetic tone. So when sympathetic tone is reduced, there is obviously vasodilation. So a spinal shock can also cause a, or a neurogenic shock can also produce a vasodilatory shock. Whenever there is anaphylaxis, histamine is released. Histamine is a potent bronchoconstrictor and a vasodilator. So that also produces a anaphylactic shock, so a vasodilated shock. The septic shock usually has a component of endocrine shock because all the enzymes, all the hormones will be utilized and there is no cortisol left in the body. So that will lead to the endocrine shock. Or if there is acute adrenal insufficiency, that leads to endocrine shock. Even in endocrine shock, there is vasodilatory shock. But if any patient who had hemorrhagic shock initially will be vasoconstricted. But here also, when all the hormones are utilized and this patient goes into irreversible decompensated shock, then he also enters into a state of vasodilation. When, because all the resources will be exhausted. When the patient has cardiogenic shock and he enters into a again irreversible cardiogenic shock. Again, ultimately there is vasodilation. It just means that all the hormones are utilized in the body, all the compensatory mechanisms are lost, and the blood vessels are just left dilated. Right? And post cardiotomy shock. So all these are the causes for the vasodilatory shock: septic, spinal, anaphylactic, endocrine, and along with that, the final stage of any shock. So vasodilation remains the final terminal pathway of any shock that is prolonged and profound in nature. So what actually happens in a septic shock? There is a organism which can be a gram positive organism or it can be a gram negative organism. The gram negative organism has endotoxin on its cell surface. It is not released into the bloodstream. It has a cell surface. On the cell wall, it has a lipopolysaccharide, which is the endotoxin, to which are attracted the macrophages. That is sufficient. It does not have to release the endotoxin into the blood. But a gram-positive organism releases its toxin, exotoxin, into the blood. When this is released, this is recognized by the cells of the immune system. Now, these immune system cells get activated, and to reach the site, they need to invade the blood vessel. So, during this process, they cause damage to capillary endothelium, or these cells release free radicals, reactive oxygen species, inflammatory cytokines. So, all of this damage endothelium of a blood vessel. So, when endothelium of blood vessel is damaged, there are two things that happen that will expose the underlying vascular smooth muscle. when the underlying vascular smooth muscle is exposed, and this also gets damaged by the inflammatory infiltrate. And when it gets damaged, normally blood vessels are always in a state of tonic contraction. So when it gets damaged, they lose their tonicity of contraction and they get dilated. So when they get dilated, there is vasodilation. Arteriolar dilation is also there. Venodilation is also there. This vasodilation will reduce the peripheral arterial resistance that will let the diastolic BP to be fall. Diastolic BP falls. But this endothelium, once it is damaged, it releases inducible nitrous oxide. There are two forms of nitrous oxide. One is nitrous oxide 1 and nitrous oxide 2. Nitrous oxide 2 is called as inducible nitrous oxide synthase, right? So this inducible nitrous oxide synthase is stimulated by the endothelial cells, and that will cause the release of nitrous oxide. Nitrous oxide will cause vasodilation. So when there is vasodilation, there are two things that happen. One is because there is vasodilation, there is a reduction in the peripheral arterial resistance that will obviously reduce the diastolic BP. But because there is vasodilation, our veins are called as capacitance veins. Almost 80% of the blood in the body is present in the veins, and it is the tone of the venous smooth muscle that is maintaining the cardiac inflow. Right? For venous return to happen, out of all the factors that we discussed yesterday, one was a negative intrathoracic pressure, other would be a positive pressure in the calf muscles, and the presence of the unidirectional valves in the vein, and also the tonicity of the veins. It is only when these veins maintain adequate amount of tone in them, there is venous return to the heart. So when there is vasodilation, there is a loss in the tone of veins, and when this tone is lost, the venous return is reduced. When venous return is reduced, end diastolic volume is reduced. That reduces the stroke volume, that reduces the cardiac output, and that reduces the systolic BP. So, in sepsis, there is vasodilation. That vasodilation, because of reduction in the peripheral arterial resistance, causes fall in the diastolic BP. But because there is venodilation also, there is no, there is reduced venous return to the heart. This reduces the cardiac output and reduces systolic BP also. Along with this, this endothelium also releases cytokines, and these cytokines will attract the neutrophils because all it is trying to do is to localize the inflammation. So it will attract the neutrophils, and it will also increase the microvascular circulation. Again, the aim of why it is increasing the nitrous oxide synthesis because neutrophils are present somewhere else in the body, or they are present uniformly distributed in the blood, but it needs more neutrophils to come to the site of the pathogen that is present. So in the attempt to recruit more neutrophils, it will increase the synthesis of the nitrous oxide so that more blood flows and more neutrophils are recruited. So it increases the microvasculature, stimulates the neutrophils. Along with that, obviously, there is a stimulation of procoagulant factors. That is the reason for consumptive coagulopathy in sepsis, that all the platelets will be consumed at one point and there is bleeding because there are no platelets left in the blood. So that is why sepsis has a reduction in the platelet count because it is stimulated, procoagulants are stimulated by the cytokines that leads to consumptive coagulopathy, and it will also stimulate the fibroblasts. So because of all these reasons, it is trying to contain the inflammation to the localized site. But if the body succeeds in controlling this inflammation, it will limit there and it produces a localized inflammation or infection. But if the virulence of the organism is much more than the attempt of a body to contain it, it will spread to the next site. And the inflammation of the body also spreads to the next site. And when it spreads to next site, it will again keep on spreading like this. As it keeps on spreading to all over the body, it will cause systemic inflammatory response syndrome. So whatever the inflammation and infection was localized, because the inflammation kept on spreading, the inflammation also kept on spreading, and that led to systemic inflammatory response syndrome. So we'll discuss this later. But now, what happens to the compensatory mechanism? So because of all these reasons, either there are two reasons for reduction in the diastolic BP and there's a reason for reduction in the systolic BP. So eventually the patient has hypotension. When the patient has hypotension, this hypotension will, the first thing that happens is, as we discussed in first class, it will cause a sympathetic stimulation. This sympathetic stimulation will release the catecholamines. And these catecholamines, when they are released, they will act onto the heart and they will act onto the blood vessel. In the blood vessel, they try to cause vasoconstriction because they are powerful vasoconstrictors. But now the nitrous oxide, whatever is released, this nitrous oxide not only causes vasodilation, but it also inhibits the vasoconstriction caused by these endogenous catecholamines. So now the only thing that a catecholamine can do is raise the heart rate. So rising of this heart rate will cause tachycardia. Also, it raises the force of contraction. Now here, preload is the amount of blood that returns to heart. So it is a preload, which determines the end diastolic volume that eventually determines the cardiac output. But afterload is every time the ventricle contracts, the ventricle has to push the blood into the aorta. Aorta has to push it further into arteries, arteries into the arterioles. But all of these have a smooth muscle and they are already in a tonically contracted state so that they offer some resistance to the ventricular outflow. Now the this is called as afterload. So afterload is the amount of the vascular resistance that is offered to the ventricular outflow, to the contraction of the heart because of the tone of the smooth muscle in the arterioles. But because here there is a increased loss of tone in the arterioles, the afterload is reduced. Along with the reduction of the afterload, the force of contraction is increased. So because of this, the cardiac output becomes supernormal, right? So because there is no resistance, whatever the heart is contracting normally, it can pump more blood also. So when it is pumping more blood, along with that, the catecholamine is stimulating the heart to pump more blood. So the cardiac output becomes supernormal and there is more flow. There is less resistance, less pressure, more flow. So these patients remain in a state of warm extremities for a prolonged period of time. But eventually, there is a reduction in the catecholamines because the reserves get exhausted and these patients become cold, irreversible shock. So if there is a septic patient with cold peripheries, it means that this patient has already entered a state of irreversible shock. So this is about the pathophysiology of septic shock. Is this clear?
Sir, the patients who are coming to casualty with peritonitis, with periapsis, all septic cases come in reversible shock only, sir. Because
So
we can't see warm peripheries, sir, in casualties.
whether the patient is in reversible shock or in the irreversible shock is not just based on one criteria. As we discussed earlier, so to tell whether the patient is in reversible or irreversible shock, you once the patient comes to you, you resuscitate these patients with fluids. Even after resuscitation of these patients with fluids, if the patients remain non-responders, it means that they have entered a irreversible shock. And one differentiating feature from the septic shock and rest all shock is that these patients already present with cold peripheries. But in septic shock, in the early stages of the septic shock, the patients will be in a warm state. But these patients developing cold peripheries at the time of presentation may be a hint towards a irreversible shock. But again, it is not just one criteria that will tell whether the patient is reversible or irreversible. It is a constellation of features, right? It is just a hint that patient may be heading towards a irreversible shock. Clear?
Yes, sir.
So after this, as I told you, if the inflammation infection is not contained, it spreads to all other parts of the body, leading to SIRS. Now you need to define SIRS. Systemic inflammatory response syndrome is defined as a temperature of more than 38.3 degrees Celsius or a temperature of less than 36 degrees Celsius, a heart rate of more than 120 beats per minute, and a respiratory rate of more than 20 cycles per minute, or the patient has a partial pressure of carbon dioxide in the arterial blood of less than 32 mmHg. Because these patients are in metabolic acidosis, there is washout of carbon dioxide and the partial pressure of carbon dioxide in the blood reduces naturally. So it is less than 32 mmHg. Or the WBC counts of this patient is more than 4,000, so less than 4,000, or it is more than 12,000, or you get a peripheral smear and you see more than 10% of immature cells. This is called as CIRS. So this is the criteria for the CIRS. So if the patient has CIRS, any two of the components of the CIRS, and along with that, if there is a suspicion of an infection or you have confirmed the presence of an infection, it means the patient is in sepsis, right? So if the patient has sepsis, along with sepsis, if the patient has any of this, the lactate level of more than 4 millimole per liter, or the BP has reduced to less than 90 mmHg. So either lactate is more than 4 millimole, it means the patient is in acidosis, or patient is in hypotension, or if the patient has a end organ dysfunction. So sepsis with any of this is termed as severe sepsis. Right? If the patient has a severe sepsis with refractory hypotension to fluids. It is to fluids, remember, not vasopressors. There was hypotension, you gave a fluid challenge. To the fluid challenge, the patient yet did not respond. That is called as septic shock, right? So any two sets with a suspected or confirmed source of infection is sepsis. Sepsis with either lactic acidosis or hypotension or end organ dysfunction is called as severe sepsis. And severe sepsis, which is refractory with refractory hypotension to fluids, is called as septic shock. Now, if there is at least two organ dysfunction, that is the criteria for multi-organ dysfunction syndrome. There has to be at least two organs that have failed. But this was an older concept. Now, the definition of sepsis is that sepsis is defined as a life-threatening condition which is evidenced by organ dysfunction due to inappropriate host response to the pathogen. So it is a life-threatening condition which is evidenced by organ dysfunction because of inappropriate host response to the pathogen, evidenced by at least two so far. So now, if you want to define sepsis, you should define it on the basis of SOFA. So any two criteria in the SOFA, a SOFA score of 2 and above is sufficient to tell that patient is in sepsis, right? With the evidence of an infection. So SOFA is sequential organ failure assessment, where each variable is given a score from 0 to 4, right? These variables include from head to toe, CNS, CVS, RS, liver, renal, and blood. Right? In CNS, they consider GCS, CVS, BP is considered. Remember, in cells, it was heart rate, not BP, but in CVS, BP is considered. Respiratory system, a PaO2, FiO2 ratio is considered. In liver, total bilirubin is considered. Renal, creat, and urine output is considered. Blood, as I told you, because of consumptive coagulopathy, platelets are reduced. Platelets are considered. So each one of these is given a score from 0 to 4, and anything more than 2 is a criteria for sepsis with the evidence of infection. Right? So because that is difficult to assess, there is a bedside score which is quick SOFA, Q SOFA. Q SOFA contains RAS. R is respiratory rate. A is altered mental status, and S is systolic BP. Right? Systolic BP here 100 is considered. Remember, not 90. and respiratory rate instead of 20, 22 is considered, right? So it is altered mental status, respiratory rate of more than 22 and systolic BP of less than 100 is a quick SOFA, which is a bedside score for SOFA. Now you define sepsis with respect to SOFA. So up you diagnosed a patient with sepsis. So the treatment of septic shock. The first would always be a criteria for airway plus ventilation, breathing, then comes to circulation. So as we discussed in a hemorrhagic shock, once you put a IV line, you send it for blood culture and sensitivity, antibiotic sensitivity, routine investigations, and a ABG analysis is taken. So you can take ABG. If ABG is not possible, even VBG will also suffice. So once you do that, the first thing here would be again a fluid challenge. So whatever is the type of the shock, apart from cardiogenic shock, it is the fluid challenge that is given first. So here a fluid challenge of 30 ml per kg body weight is given. It is given over 4 to 6 hours. But remember, if the patient has hypotension of less than 90 mmHg, or if the patient has lactic acidosis, then you complete this 30 ml per kg within 3 hours. So 30 ml would be for a 70 kg male, it would be around 2 liters. So you complete this 2 liters within 3 hours. But if not, if there is no lactic acidosis or the BP has not yet fallen to less than 90 mmHg, you can give it over 4 to 6 hours. Once you give the fluid challenge, if the patient is responding, you bring it down to maintenance fluids. As I told you, for first 10 kg, it is 40 ml per kg. Next 10 kg, it is 20 ml per kg. And rest all about 20 kg, whatever is the weight of the patient, it is 1 ml per kg of body weight. That is, you shift to maintenance fluid, just like in hemorrhagic shock. If they do not respond, you add a vasopressor. And because there is vasodilation, the first vasopressor of choice would be a noradrenaline. Noradrenaline is better than adrenaline, right? If they do not respond to this vasopressor, you can add a dobutamine. So dobutamine will act on the alpha and beta receptors. It stimulates the beta 1 receptors of the heart, causing increase in the force of contraction. Also, it stimulates the alpha receptors and it also causes the vasoconstriction. You add a dobutamine. Then you start with empirical antibiotics and also think about source control. For example, if the patient has pyonthorax, try to put an ICD once the BP starts to pick up. If the patient has peritonitis, but the patient cannot be taken for OT at the current vitals, you try to put a abdominal drain. If the patient has severe peritonitis because of GB perforation, try to put a drain into the abdomen. Or if the patient has a mucocele or the pyocele of the gallbladder, you can try to put a percutaneous cholecystostomy tube. So you try to get a source control along with the empiric antibiotics. Now there was something called as sepsis survival bundle. So according to this sepsis survival bundle, any patient who comes to you with sepsis within first 3 hours, there are some things that you need to do to increase the outcome of the patient, and there are some things that you should do from 3 hours to 6 hours. So first to 3 hours, the first step would be to send for culture and sensitivity of this patient, and the second step would be to send for lactate levels. Third, you start these patients on fluid challenge of 30 ml per kg. Along with that, you also start these patients on empirical antibiotics. I told you fluid is 30 ml per kg, but if the patient has hypotension or lactic acidosis, you give it within 3 hours, first 3 hours. And next, in the next 3 to 6 hours, if the mean arterial pressure, even with the fluid challenge, if the mean arterial pressure remains to less than 65 mmHg, you add a vasopressor. And you see that the CVP of the central venous pressure of the patient is remaining to more than 8 mmHg, and the venous oxygen saturation. See, you see the arterial oxygen saturation, it should be 100%, right? Because the arterial blood has to be 100% saturated with the oxygen. But you measure the venous oxygen saturation, it will be around 75%. It means when the blood passes in front of a cell, this cell will take 25% of the oxygen present in the that amount of blood which is passing through it. So when you take a venous oxygen saturation, it has to be normally 75%. But you try to maintain the venous oxygen saturation to at least 70%, right? And you remeasure the lactate. You keep on doing this and manage the fluids and vasopressors to maintain this as a goal, these things as a goal that will improve the outcomes of the patient. Along with that, initially, because there is a release of catecholamines, these catecholamines, all the hormones in the body are hyperglycemic. So these hormones called hyperglycemia, and in the state of shock, there is already peripheral insulin resistance. So hyperglycemia with peripheral insulin resistance will further elevate the blood glucose level that will further cause the accentuate sepsis. So initially, if the blood glucose level was more than 216 only, they used to add insulin. But now there are few changes. You try to maintain the blood glucose levels within 80 to 110 mg per deciliter. If it crosses 110, even if the patient is non-diabetic, use insulin. It is only insulin because there is a insulin resistance. Use insulin if the blood glucose level becomes more than 110 mg per deciliter. Second, because of these sepsis, these patients can go into ARDS. Remember, any patient, because of any reason, if there was a hemorrhagic shock, he went to ARDS, you transfused blood, patient went into ARDS. The first thing is obviously there is fluid restriction. Along with that, you try to put these patients on mechanical ventilation, right? You sedate these patients so that the work of breathing is reduced. Because when the work of breathing is not reduced, the tidal volume increases. Increase in the tidal volume will only worsen the ARDS. So, if the patient is in ARDS, try to sedate the patient and put him on mechanical ventilation, right? To this mechanical ventilation, you reduce the tidal volume, make sure that it is less than 6 ml per kg. Normally, in a mechanical ventilator, we keep tidal volume to around 12 to 15 ml per kg body weight, but try to make sure that the 6 ml per kg body weight and less than that is maintained. Along with that, you increase the positive and expiratory pressure. Remember, if it was a case of obstructive shock, do not increase PEEP, keep PEEP low because that will interfere with the venous return. Here, because there is ARDS, you need to push the air into the lungs against the resistance from the fluid in the lungs. That is why you increase the PEEP. If this is not possible, at least try to make the patient to be in a prone position. Right? This is second. And third is about whether to use steroids or not in a septic shock. What initial studies said that if the patient is in septic shock, routinely single dose of 50 mg IV hydrocot was given because there is endocrine insufficiency in these patients. 50 mg of hydrocot was routinely given as a single dose. But now the only criteria to give steroids is that patient is in an established septic shock and his hypotension is refractory to both IV fluids and vasopressors. You gave the fluid challenge, patient did not improve. You started him on vasopressors, still did not improve. You added robitomine, then also patient did not improve. Then only this is an indication for steroids. Of course, under antibiotic coverage, right? Now, the steroid of choice is IV hydrocot, 200 mg per day. You can give it as a 4 divided doses or a continuous infusion for 7 days. Just don't give it for 1 day and leave. So, if the patient is in septic shock with refractory hypotension to both fluids and double inotropes, then that is an indication for a steroids. You add IV hydrocot 200 mg per day either in 4 divided doses or a single day for 7 days. This is about the septic shock. Now there is one more small topic, rather a dry topic, which is called as the biomarkers of sepsis, which has been asked a couple of times. Till now, any doubts? Hello, hello.
No, sir.
So these biomarkers of sepsis are of two types. One is a diagnostic biomarker and other is a prognostic biomarker. The diagnostic biomarkers are presepsin, pentraxin, calprotectin, and gut microbiota. These help only in the diagnosis. But the prognostic markers are adrenomedullin, mid-region segment of proadrenomedullin, and bioadrenomedullin. One. It is also RNS, which are non-coding RNS, micro non-coding RNA, and a long non-coding RNA, and angiopoietins. Rather a dry topic, I'll try to reason it as reasonably as possible. Right. So these are the newer biomarkers of sepsis. So diagnostic include presepsin, pentraxin, calprotectin, and gut microbiota. Prognostic include adrenomedullin, mid-region segment of the proadrenomedullin, bioadrenomedullin, micro and long non-coding RNA, and angiopoietins. So we'll take them one by one. First is a presepsin. Now, whenever there is a gram-negative bacteria that enters, it has a lipopolysaccharide on this surface, and we have a macrophage in our body. This macrophage has a cell surface receptor called as CD14. This CD14 will take the macrophage up to the gram-negative bacteria, attach to the lipopolysaccharide, and it will cause the phagocytosis of the gram-negative bacteria. So, CD14 is a cell surface marker present on the macrophage, which will recognize the lipopolysaccharide, bind to it, and cause the phagocytosis. When that phagocytosis happens, so this CD14 is a protein. So, a protein has a C terminus and a N terminus. So, once there is phagocytosis, this N terminus it cleaves, right? It cleaves into multiple subunits. One of that subunit is a 53 kilodalton protein. It is a glycopeptide and that is called as presepsin. Right? So presepsin is a soluble glycopeptide. All these should be soluble. If they have to be measured in the blood, obviously they have to be soluble. So it is a soluble glycopeptide, which is a cleavage product of N terminus of the CD14, which is a cell surface marker of a macrophage. So, what is the role of this in sepsis? It is one of the earliest marker of sepsis. It is elevated earliest than any of the other markers. Second is because it is present on the macrophage that phagocytosize a gram-negative bacteria, it will differentiate a gram-negative sepsis from gram-positive sepsis. Also, it will quantify the sepsis. Greater is the amount of this PSEP, it means that greater is the amount of the phagocytosis that is happening. So, greater will be the bacterial load in the body. So, that is about presepsis. Next is pentraxins. See, if there is a cell in the body and this cell undergoes necrosis because of some or the other reason. Now, this cell has to be recognized by the body that it is not a normal cell, it is a cell which has undergone necrosis. So for that, the cell itself expresses on its surface something called as damage associated membrane protein called as a DAMP. So this cell on its surface expresses DAMP to tell the immune system that I am necrosed cell, I am not a normal cell. Similarly, any pathogen that enters into our body, this pathogen also expresses a cell surface marker, which is a pathogen associated molecular protein. So these are DAMP and PAM. So these are the things which are expressed onto the necrotic cell or a pathogen. So these can be a toll-like receptor, it can be a nod-like receptor, it can be a rig-like receptor, or it can be a C-lectin receptor. So these are the some of the examples of PAM, right? So toll-like, nod-like, rig-like, and C-lectin receptors. So when these are expressed on they have to be recognized. Now these are recognized by the surface markers which are present on our cells, which can be a cell of our immune system. It can be a monocyte, it can be a macrophage, it can be a neutrophil, even a dendritic cell, or a vascular smooth muscle cell, or an endothelial cell. Basically, any cell in the body will recognize these patterns. Because they recognize these patterns, they are called as pattern recognition molecules. Right? So they are PRMs, pattern recognition molecules, which recognize the DAMP or PAM. So these pattern recognition molecules, if they are soluble in the blood, they can be measured. And those soluble PAT molecules are called as pentraxins, right? So pentraxins are the soluble pattern recognition molecules which recognize the damp on the necrotic tissue and PAMP from a pathogen, right? Which are expressed by all these cells. Even hepatocytes express this. So these pentraxins are of two types. Again, these pentraxins also have their end terminus. Depending upon the length of the end terminus, these pentraxins are classified as a short pentraxin and a long pentraxin. The long pentraxins are neuropentraxin 1, neuropentraxin 2, pentraxin 3, and pentraxin 4, of which the most studied and most clinically useful is a pentraxin 3. Right? So this is one. The short pentraxins are the pentraxins which are stimulated by the interleukin 6, a hepatocyte. Whenever there is a inflammation, this inflammation will stimulate the interleukin 6, and this interleukin 6 will stimulate the hepatocyte, and this hepatocyte releases C-reactive protein. So this C-reactive protein is one of the pentraxin. The normal value is less than 3 gram per liter. In 1 liter of blood, it should be less than 3. It can be increased to 20, 30, but when there is a severe sepsis, it can be increased to 1,000-fold within 24 to 48 hours also. And it is diagnostic. It is not prognostic. Like there is CRP, you give a treatment today. After 2 to 3 days, you check again. If the CRP is not reduced, do not think that it is not the treatment is not working. So CRP is a diagnostic factor, not a prognostic factor. So this is CRP. And second would be a serum amyloid peak. So these are the short pentraxins which are secreted by the hepatocyte, and the long pentraxin include NP1, NP2, pentraxin 3, and pentraxin 4. Right. So this is about pentraxins. And then there is a calproctenin. This calproctenin actually is a heterodimer. It has two subunits. One is a subunit A and another is subunit B. Now, subunit A is called as calgranulin A and subunit B is called as calgranulin B. Right. So this is S100 is expressed on calproctenin. So this is S100A8. This would be S100A9. Right. So this calproctenin is involved in the calcium, zinc, and magnesium metabolism. Along with that, the levels of calproctenin are also increased in sepsis, right? So this is about calproctenin. Third, The fourth would be gut microbiota. As we discussed in the primary sclerosing cholangitis chapter, gut health is very important, and the they have studied from various diseases. They have taken a sample of the colon and also the fecal microbiota study has been done. You can even get a fecal calprotectin levels also. So it shows that in most of the diseases in the body, there is a alteration in the gut microbiota. So the gut microbiota is involved in the genesis of inflammatory bowel diseases. It is also involved in genesis of diabetes mellitus and its associated complication atherosclerosis. You also know that it is obviously involved in primary sclerosing cholangitis, so that is why it can also be involved in cirrhosis of the liver. Gut microbiota is also important for the endocrine function of the intestine. It is obviously more important for the digestive function. So these are the things where the gut biota is increased, and whenever there is a sepsis, there is alteration in this gut microbiota. So that also serves as a marker. So all these are diagnostic markers. Now, prognostic marker, sir, adrenomedullin, mid-region segment of adrenomedullin, proadrenomedullin, and bioadrenomedullin. So these are the prognostic markers. So this adrenomedullin, if you measure it, it will tell you the severity of the sepsis. And proadrenomedullin will tell you the stratification of sepsis. It means which patients can go in for sepsis early, right? So these are the things about the adrenomedullin and bioadrenomedullin. Just remember their names. That is sufficient. That should be sufficient. Right? So the second would be angiopoietin. So these angiopoietin and endothelial cells, in response to the sepsis, secretes angiopoietin. This angiopoietin acts onto the endothelial cell only, and this causes the all the effects of the sepsis. So there are two angiopoietins, angiopoietin 2 and angiopoietin 1. If the ratio of angiopoietin 2 to 1 is increased, or if the levels of angiopoietin 2 are increased, it indicates that there is severe sepsis. And the last would be non-coding RNAs. So normally a DNA will transcript its information onto the RNA. RNA comes out of the nucleus and translates the same information onto a protein, right? But there are some RNAs which are non-codings. They do not code for anything. So out of which one is a micro non-coding RNA and long non-coding RNA. Long non-coding RNA will be made up of more than 200 nucleotides, and microRNA will be made up of 20 to 23 nucleotides. So this constitutes to 1% of all the genome, but it regulates 50% of the coding proteins. Right? So once it comes out, it will be a double-stranded RNA. It has a guide strand and a passenger strand. The guide strand will guide the translation of these proteins. It will regulate the translation of these proteins. But passenger strand is just staying there whenever there is necrosis or there is an inflammation. This passenger strand comes out of the cell and comes detected in the blood. So an increasing level of microRNA will tell you that there is an ongoing necrosis in the body. So the long non-coding RNA is also similar to the microRNA, just that it has more than 200 nucleotides. And the two important non-coding RNAs are NEAT1 and NEAT2. This NEAT2 is also called as MALAT, which is increased in non-small cell lung carcinoma. And NEAT1 is increased in sepsis, right? Also, calprotectin is released in the myeloid cells. Because it is released by the myeloid cells, these myeloid cells are the ones which are activated in bacterial infection. So it helps us to differentiate a bacterial and a viral infection, especially pneumonia. So this was about this. But what are the uses of these biomarkers? One, if the patient is at high risk for development of sepsis. It will identify sepsis. It will screen sepsis in those patients because they detect sepsis early. So screening of high risk patients. And if they develop, it will stratify the risk for developing sepsis. They will help us to diagnose the sepsis. They will help us to prognosticate the sepsis, and they will predict the outcomes, mortality and morbidity. For any agent to be a ideal biomarker, it should be testable, and that test should be reproducible, and those tests should be cost effective, but they are not. And it should have normal biology, physiological functions, and it should replicate the pharmacological aspects of the treatment so that it can be used for prognostication. And so this is about biomarkers, a very dry topic.